So good morning, everyone. Thank you very much, Chairman. I'm Takafumi YANAGISAWA from the University of Tokyo, Japan. It is a great honor to have the opportunity to speak at such an exciting symposium. Today, I'd like to summarize the current status of management of muscle-invasive bladder cancer to optimize cystectomy outcomes. So radical cystectomy is the standard treatment for muscle-invasive bladder cancer. However, this operation suffers high rates of perioperative complications, poor patient quality of life, and poor prognosis compared to other organ-confined urological cancers. So in order to achieve better outcomes, we need to consider many things that affect outcomes. Proper operative systemic therapy is indeed necessary for optimal oncologic outcomes. Hence, this talk will focus mainly on systemic therapy and slightly on surgical techniques. Prognosis of muscle-invasive bladder cancer is still not satisfactory, depending on pathological stage. Despite an appropriate radical surgical approach, there is a substantial risk of recurrence that increases when extravesical tumor extension or node positive disease exists. So these are generally caused by non-local events as a result of metastatic disease. Only systemic therapy could eradicate micrometastatic disease. So perioperative chemotherapy, such as neoadjuvant and adjuvant therapy, is key to success in the management of muscle-invasive bladder cancer. These are well-known, reasonable treatment strategies, but have pros and cons according to patient condition and pathophysiology. So neoadjuvant chemotherapy is a biologically reasonable treatment strategy. Patients are more fit to chemotherapy. Systemic therapy can be provided when pelvic blood supply is intact and deal with possible micrometastasis immediately. It also might facilitate surgery by decreasing tumor volume. In addition, if post-operative complications happen, adjuvant therapy must be delayed. In 2003, an RCT by Dr. Grassman demonstrated the survival benefit of neoadjuvant chemotherapy. Neoadjuvant MBAC plus radical cystectomy showed significant and clinically meaningful improvement in overall survival and disease-specific survival compared to radical cystectomy alone. In addition, this study showed significant survival benefit in patients who achieved pathological T0 following neoadjuvant chemotherapy. Neoadjuvant MBAC achieved 38% of pathological T0 on radical cystectomy specimen. Since then, neoadjuvant cisplatin-based chemotherapy has been popularized in the management of muscle-invasive bladder cancer. Results from meta-analysis, including 11 RCTs, supported the significant overall survival and DSS benefits for neoadjuvant chemotherapy. Based on these evidence, EU guidelines strongly recommended to offer cisplatin-based neoadjuvant chemotherapy to cisplatin-fit muscle-invasive bladder cancer patients. To assess optimal regimen for neoadjuvant chemotherapy, the VESPA trial comparing 4 cycles of DC with 6 cycles of dose-dense MBAC was conducted and published in 2020. This study comprised 88% of patients who received chemotherapy as neoadjuvant setting, but including 12% of adjuvant setting. Dose-dense MBAC resulted in significantly better pathological CR rates and progression-free survivors compared to GC. So in the neoadjuvant setting, dose-dense MBAC resulted in significant overall survival benefit with hazard ratio 0.7 compared to GC. So toxicity is an important aspect, especially for neoadjuvant setting. The treatment rates of dose-dense MBAC was lower than GC regimen. And as you can see, dose-dense MBAC was associated with increased risk of nausea, asthenia, anemia, and febrile neutropenia. But importantly, these are mostly manageable. Dose-dense MBAC appears to be feasible in practice. Based on sub-analysis of VESPA trial, higher cumulative cisplatin dose was found to be associated with better overall survival. Therefore, 6 cycles of dose-dense MBAC with careful management of adverse events should be considered the standard of care for neoadjuvant chemotherapy. And numerous Previous phase 1 or 2 trials have assessed the efficacy of immune checkpoint inhibitors as neoadjuvant therapy. Compared to 42% of pathological CR rate for dose-dense MBAC, immune checkpoint inhibitors plus chemo combination seems to be beneficial, but not a big change. When synthesizing this trial, ICI plus chemo combination achieved the highest pathological CR rate compared to other combinations or chemotherapy or ICI alone. ICI plus chemo combination seems to be promising. So recently, the results from Niagara trial have just been published. This study assessed the impact of perioperative durvalumab adding to GC. Perioperative durvalumab included 4 cycles as neoadjuvant and 8 cycles as adjuvant therapies. So perioperative durvalumab significantly improved disease-free survival with hazard ratio 0.68 and improved 2-year overall survival. In addition, this combination provided safety profile even when comparing to GC. Perioperative durvalumab plus GC combination is promising with improvement of overall survival with safety signals. Next, let me briefly introduce the surgical management during radical cystectomy. So robot-assisted radical cystectomy has been widely adopted. Compared to open radical cystectomy, the non-inferiority of oncologic outcomes and benefits of perioperative outcomes for robot-assisted radical cystectomy has been demonstrated by randomized control trial, as well as meta-analysis. And next, as for the optimal extent of lymph node dissection, 2 RCTs has been conducted, and the results of SWOG S1011 trial has just been published in the New England Journal of Medicine this month. So these are study designs of 2 RCTs. 2 RCTs slightly differs their inclusion criteria and patient demographics. However, these trials consistently failed to show any survival benefit of extended pelvic lymph node dissection. In addition, SWOG trial showed higher 90 days severe complication and mortality rates in the extended pelvic lymph node dissection group. So taken together, extended lymph node dissection during radical cystectomy is no longer recommended. Another important point of view is urinary diversion. We need to discuss each patient to determine the optimal urinary diversion. Orthotopic neobladder potentially offers better patient QOL, maintaining body image. But in the era of robot-assisted radical cystectomy, the another binary choice is whether intracorporeal or extracorporeal urinary diversion. So emerging evidence have put an argument of intracorporeal versus extracorporeal. Real-world data from Asia, as well as meta-analysis, consistently show the utility of intracorporeal urinary diversion in improved perioperative outcomes, such as lower transfusion rates and shorter hospital stay, without increasing the risk of post-operative complications compared to extracorporeal urinary diversion. So next, let's look at the urinary diversion types of the famous RCT. This laser trial, published in Lancet in 2018, randomizing 150 cases of each, all urinary diversion was performed extracorporeally, and the rate of neobladder ranged 20 to 24%. And this is IRC study, the same design RCT of robot versus open, published in JAMA in 2022. This study demonstrated the statistically significant differences in median days alive and out of hospital, 2.2 days longer in the robot-assisted radical cystectomy group. In this trial, all urinary diversion was performed intracorporeally, and the rate of neobladder was only 10 to 12%. So globally, the rate of neobladder has recently been decreasing. One possible explanation for this is introduction of robotic surgery and a need for simpler intracorporeal reconstruction may have encouraged the trend away from neoadjuvant use. But the global data suggests that the change was happening before wider dissemination of robot-assisted radical cystectomy. So rather than wider dissemination of robot-assisted radical cystectomy, there are several possible explanations For example, lack of high-quality evidence that the neobladder offers superior health-related QOL to an ileal conduit. Most common issues for patients are not body image changing. The current trend in cystectomy is towards reducing the burden of surgery through prehabilitation, enhanced recovery, and minimal access approaches. Neobladder use lead to longer hospital stays and longer learning curves before inpatient stays. Finally, I will shortly summarize current status of adjuvant therapy. Even after differential therapy with neoadjuvant chemotherapy and radical cystectomy, more than 60% of YPT2 and or not positive patients have risk of recurrence leading to death. Optimal treatment regimens should be developed for patients who already received adequate neoadjuvant chemotherapy. Immune checkpoint inhibitors have also been assessed for urothelial carcinoma in the adjuvant setting. There are 3 RCTs assessing the impact of adjuvant atezolizumab, nivolumab, and pembrolizumab in patients who received neoadjuvant chemotherapy with YPT2 to T4 who are not positive disease, or patients who did not receive neoadjuvant chemotherapy and were pathological T3 to T4 were not positive at radical surgery. Only in the CheckMate 214 trial, the comparator arm was placebo. Other trials were observation. So unfortunately, the PD-L1 antibody and atezolizumab did not prolong DFS and OS. These data do not support the use of atezolizumab in the adjuvant setting. The results of Ambassador trial has been presented in ASCO GU 2024. Significant DFS benefit with hazard ratio 0.69 was seen in patients treated with adjuvant pembrolizumab compared to observation. However, even when considering immature OS data, and 27% of patients in the observation group were treated with immune checkpoint inhibitor as subsequent therapy, overall survival was completely similar between the two groups. In the CheckMate 274 trial, as you can see, adjuvant nivolumab significantly improved not only DFS, but also overall survival. So to sum up, there's 3 RCTs based on network meta-analysis. So pembrolizumab was the highest likelihood to improve DFS, closely followed by nivolumab. So only nivolumab improved overall survival. So what are the demographic differences between the 3 RCTs? So first is the rate of neoadjuvant chemotherapy administration. The Ambassador trial had the highest number of patients treated with neoadjuvant chemotherapy. Second is the rate of patients with upper tract. The INVIGO 010 trial had the lowest number of patients with upper tract. So this might have affected the oncologic outcomes. As for disease-free survival, we have run a lot from 3 trials. First, 2 agents, adjuvant nivolumab and pembrolizumab, had a significant disease-free survival benefit compared to placebo observation. And second, these 2 trials consistently demonstrate the preferable efficacy of immune checkpoint inhibitors in patients with bladder cancer and those who treat with neoadjuvant chemotherapy. Third, all RCTs consistently failed to show the DFS benefit in patients with upper tract urothelial carcinoma. Fourth, PD-L1 positivity was not predictive of treatment efficacy. Again, only nivolumab showed overall survival benefit in this setting. So we conducted pairwise meta-analysis comparing adjuvant ICI versus placebo or observation, comprising the 3 RCTs. Adjuvant immune checkpoint inhibitors significantly improved disease-free survival based on 2 positive trials. In addition, our analysis showed that adjuvant immune checkpoint inhibitors significantly improved overall survival. So subgroup analysis supports the results that I mentioned before. Patients treated with neoadjuvant chemotherapy and those with bladder cancer were more likely to benefit from adjuvant immune checkpoint inhibitors. To sum up my talk, basically neoadjuvant chemotherapy is recommended for cisplatin eligible patients. 6 cycles of dose-dense MBAC should be offered when feasible. Despite neoadjuvant chemotherapy and radical cystectomy, patients with greater than YPT2 or not positive should be offered adjuvant nivolumab. In case that neoadjuvant chemotherapy was not performed, Patients with greater than PT3 or not positive should be offered for adjuvant therapy based on cisplatin eligibility. Last but not least, optimal candidate selection is an important aspect of successful adjuvant immune checkpoint inhibitors. In a post-hoc analysis of INVIGO-010 trial, circulating tumor DNA positively was predictor for the efficacy of atezolizumab. So several phase 3 trials of perioperative settings are ongoing, mostly assessing the efficacy of neoadjuvant and adjuvant EV plus ACIs. I hope that these novel combinations further improve the outcomes in patients with muscle-invasive bladder cancer. So in conclusion, as neoadjuvant chemotherapy, dose-dense MBAC or durvalumab plus DC should be offered as standard regimen, and RARC plus IGAT is preferable surgical approach. Extended lymph node dissection is no longer recommended, and adjuvant nivolumab has impressive DFS and OS benefit. So to avoid overtreatment, circulating tumor DNA will help better select patients who are likely to benefit from adjuvant therapy. So surgeons need to work within multidisciplinary teams and offer all suitable choices to affected individuals, including neoadjuvant, bladder reconstruction, open robotic surgery, bladder sparing approaches, and preoperative chemotherapy. So thank you very much for your attention.